we can probably go ahead and get started. Welcome everyone to our last session of our HEAT, Health Equity Anti-Racism Training Series. So this is our last of the virtual series for this year. And then of course, the hope is to keep these going. Tonight's topic is on community partnerships and engagement. Before I introduce our speakers for the evening, though, we do have a few sponsors tonight. So you can see the logos on the first slide, but two of them have slides, and then we've got a speaker for one of them. So first up, we've got APA Inc. So Kristen, I guess if we can get their slide up. And Kristen, if I try to go too quickly with these, let me know, but 30 seconds feels like forever when you're on Zoom. And then our next sponsor is Janssen. All right, and our last sponsor for this session is PRMS, and I believe they've sent a speaker to talk briefly.
Yes, is she? I did see her join. Nikki Travis. Nikki, hi Nikki, are you there? Well, maybe we can do the first talk here, and then we'll circle back to her in between the two speakers. Or is she? Wait, is she joining? Nikki?
There we go.
Good afternoon. I just wanted to say, I'm sorry, I was having some technical difficulties. I just wanted to say thank you for letting us be a sponsor, and we wish you all the best for the Illinois Psychiatric Society. Thank you.
Thank you for being here. We appreciate it.
No problem. Thanks.
Okay, well, that gets us to onto our speakers. So let me introduce everyone. So we have basically speakers from two groups. We've got two representatives from NAMI, Illinois. So first, we've got Laura Martinez, who is the Mental Health Equity and Inclusion Director for NAMI, Illinois. She also has served as an executive director for other chapters of NAMI in the past. She's also had a tenure with Amita Mercy Medical Center as the supervisor of interpreting and translating services. So lots of work in equity and access to care. And then we've got Andrew Wade, who is the executive director of NAMI Illinois, took over that leadership position in February 2020. So of course, that means he's been doing a lot to move things forward there. He also has prior experience in consulting and leadership in various social impact organizations, including Build Chicago, Metropolitan Family Services, the Instituto del Progreso Latino, Ounce Prevention Fund, and the Chicago School Leadership Cooperative. And then our other group of individuals is from Thresholds. So from Thresholds, we have Dr. Wesley Cook, who's the Chief Medical Officer at Thresholds. He has training and background in addiction medicine and is board certified in that. He does a lot of work with the dual diagnosis populations. He's been chief of addictions medicine at Michael Reese Hospital and an instructor at the University of Illinois Psychiatry program. Director of Thresholds since 2016. So, and then also became the CMO then this year. And then also from Thresholds, we have Tim DeVitt, Dr. DeVitt, who has a long history of providing community-based care as well. So he's been working at Thresholds to oversee an array of community-based programs, including programs in integrated mental health and substance use, residential treatment, assertive community treatment, and substance use outpatient and intensive outpatient programming. He's done work in street outreach and arrest deflection in Chicago communities. He's also done multiple presentations nationally and had multiple publications in this area as well. So To start us off, our speakers from NAMI, Illinois will begin, and then we'll roll over to our folks from Thresholds, and then we'll open it up to questions from everyone. So Laura and Andrew.
All right. I think Laura is going to flash the slides up. Nope. Is it up? All right. Why don't we go to the next one? Boy, I hope this isn't the Harper College presentation. Oh, no, it isn't. I'm sorry, I didn't change the label. Anyway, I'm Andy Wade. I'm the executive director of NAMI, Illinois. And NAMI, Illinois, or NAMI is the statewide, NAMI, Illinois is a statewide organization of the National Alliance on Mental Illness. And we're the largest grassroots network of people working on behalf of and with and for people who and families with lived mental health experience. I want to first start off by just saying thank you. Meryl Sosa is on our board of directors and has been a real asset for us. And so we were, when Laura mentioned the invitation, I really wanted to just be here myself. Also, just because this is something that I'm passionate about in my own work. Just a little bit about NAMI. We are the grassroots. We are a non-clinical support organization. Our expertise is our experience, but our programs are evidence-based, and they also come from decades of community building on behalf of and with really one of society's most marginalized communities. So people with mental illness or mental health conditions know what it's like to be excluded and left out and marginal. Just about how we work, we are an affiliate-based organization. So the statewide organization provides support and information and advocacy in coordination with our 19 local affiliates. All of our programs are free. The signature programs are some of the support groups. Laura will show you a little bit later. But they're all delivered by people who have lived this. And I think that's actually the authenticity of NAMI that is its truest power. Like many of you, we know that our state is changing. It's changed. When I came in about 3 weeks before the pandemic, and I'd been working on in a little village in Chicago with an organization serving Latinos, and we did our survey on the impact of COVID, and within 3 weeks, what we saw was that 31% of people, 3 weeks of the pandemic, were reporting mental health concerns. But we didn't use the word mental health when we asked. We asked about stress and things like that. So it really jumped out that some of the stereotypes about whether people are interested in getting mental health support are not all that true and not all that helpful. So we serve about 50,000 people with our signature programs, and there's a version of this map that shows exactly where we are. What you would see is that while 50,000 people sounds like a lot, there are whole areas of the state of Illinois we're not reaching. There are 13 million people in the state. So if we're only reaching a fragment of them and not in every community, and we're certainly not reaching every audience, we're not doing a good enough job. So our approach to equity is based on the idea that you can't build a mental health system for everyone if we're only meeting the needs of some of us. So we'll go to the next slide. I don't think I'll put a lot on the data for this. I think you're a psychiatrist, you understand data. And I don't think any of the issues that you're going to see on the screen would come as a surprise to anybody in this call. The decades of inadequate access and neglected systems and discriminatory patterns, they're not benign. And the effects of this are not evenly felt. So I put the data up mainly to say that, if we want to build bridges and create a mental health community that really brings Illinois together, we have to start from a place of truth telling. So the facts are real. Science is real and racism is real. So this is something that affects all of us in ways that we don't always see. And as mental health activists, we feel our obligation is to engage every constituency until everybody's needs are met. So, Laura, were we going to go to the next one or were we going to switch? Oh, okay. Laura's going to talk a little bit about how we went about coming up with our strategy, but I wanted to just sort of highlight the big three pieces. After meeting with a lot of people and learning and borrowing from experience and our partners, we've landed on three working strategies. We've actually recruited new people to our board. So if you go back. So these strategies will be evolving, but it's pretty simple. Number one is to double down on a couple of cross-cutting systemic issues that put equity issues on the table and focus us towards solution, but that also bring us together. So the two pieces that we've been focused on most, one is we're calling it an architecture for inclusion, but we're looking at behavioral health, workforce diversity, and also scale. So our focus has been at the front end of the pipeline, peer support specialists, community health workers, other categories, because if we want to build a workforce that reflects the people of our state, we need to go where people are. And so in terms of reaching many numbers and finding people who are doing the work, we're starting at the beginning. When we began framing the idea of architecture for inclusion, we took a lot from SEBA's study. Workforce has been in crisis for a while, but we asked the questions, what would it take? And to build a complete and inclusive workforce. Three big themes jumped out. One was mentorship and support communities systematically, really starting early, but all the way up through your professional association. So some of the folks we work with, there's a wonderful woman named Leela Ellis-Watkins who runs an organization called Coffee Hour, which is a network of some 900, mostly Black and some Latino mental health professionals. It's a support group for them. Mentoring programs like We Are Men, which is for MSWs. So mentoring and support communities is something that is one of the big pillars we're looking at. The other is expanding the pipeline and career pathways. We come out of, some of our work has been with workforce development. And we know there are organizations where you can go in as a high school push out, go into their nurse assistant program and come out in RN. So we're looking to adapt those structures in that community into the mental health workforce conversation. And then the third piece is just a sustained investment in people. People who are coming, especially if you're coming from humble means or facing challenges, need scholarships, need support services. The investment in that needs to be larger and more systematic. The investment's also, policy and systemic. So we look a lot at, parity, Medicaid rate, access to meds. So that's the biggest piece right now. We're getting ready to do some issue briefs and really excited on that. The other cross-cutting issue is 988. Reinventing crisis response is more than a phone number. What rolls out in July is just going to be the beginning. So the three pieces we're focusing on, and we'll be doing some campaign on that, is the three pieces of the crisis response system: someone to talk to, an appropriate, safe response, and safe places to get well. The other pieces of our strategy are really about the partnerships, and I'm going to hand most of that over to Laura. But what became really clear when we were reaching out on mental health workforce was While issues that touch many communities are critical, every community experiences things in different ways. And so embracing the uniqueness of every community is something that is a starting point. The differences matter. Oh, Laura, that's a great picture. I think I've been to that restaurant. So basically our role or our job is to build a strategy and a network to reach every community. We're not that big though. So really, this is one of those things that begins by listening and finding out what people are already doing and being willing to follow and being eager to follow, frankly, if people are doing things that we can be supportive of. So really, our second strategy is to build community that reaches everyone and includes everyone. And then the last one is just to look for every opportunity to widen the playing field. There are lots of people who a year before COVID would have never imagined reaching out on a mental health concern. And the people that affects every group, every constituency, every community, that's everyone. So we're seeing that as we look to scale up, we need to open doors. And so we've been working with our national organization to roll out some culturally competent programming focusing on our Black and Latino communities as a starting point. We're also looking at things like Mental Health Awareness Month as an opportunity to build some new bridges, particularly in areas where we're not doing well. So geographically, we're looking a lot downstate, but also in terms of constituencies, we're focused on people of color, LGBTQ communities, really the whole range. So that's what we're doing. Laura, I think we'll go over and talk a little bit about how we did it. Are you muted?
Laura, you're still muted.
Sorry about that. So yes, thank you so much, Andy. We all know that there's a lot of need in different communities. We're not just talking about ethnicity, race, or gender. Even within our own families, we have different needs. Our parents, we were raised from the same parents, but each of us are different. So we all have different needs. And so we are addressing the needs of our communities. We understand that there's a difference between each community. And the way we started doing this is right now, like Andy mentioned, is the need for the Black and Hispanic community. They seem to have been very impacted by by COVID, but even before COVID, being an immigrant or being a person of color, they're very different and they have different needs and the culture is different. So we created, National started with, sorry, I'm gonna turn this off because my computer's not, technology, yep, there we go, it wouldn't go. My computer has a mind of its own, sorry. So we created, NAMI National started with two programs, two initiatives that are called Sharing Hope, and this is strictly and exclusively only for the Black community. And then we have Compartiendo Esperanza, and that is only and exclusively for the Latinx community. And I want to make that clear because we want to give each community a space to really talk about what is going on with their community. For Sharing Hope, what is going on within the Black community, what is keeping them up at night, what is worrying them. And we know that these communities are not very open to talking about mental health. So what National did is created 3 videos, one for the community, one for family, and then one for individual, for the youth. Compartiendo Esperanza and Sharing Hope are basically the same thing. The only difference is that one is for the Black community, Black and African community, and the other one is for the Latinx community. So what this gives them is a chance to watch a video and start a conversation about mental health. And the beauty of this is that it doesn't have to be about anything. It could be anything that's bothering them. It could be anything that they're happy about, anything that keeping them up at night. So what the facilitators are doing is while they're having these conversations, they are looking to see the participants and really listening to see if any of the participants are needing help with any services, any resources. And basically the initiative is working as a bridge to take the participants to our support groups to get that mental health support and services and resources that they need. So basically that is the initiative goal, to have people really talk about mental health. As I said, in some communities, there is really, I believe that there is a taboo. In a lot of the communities, and I know that in the Hispanic community, the word, mental health, right away, people push back and say, no, I don't have a problem, I'm okay. So it's very hard to admit, but if we are putting it in a way that, hey, let's just have a conversation, it's a lot easier for people to open up. So that is Compartiendo Esperanza and Sharing Hope. We have really expanded our focus on diversity and inclusion and equity. We are working on providing the signature support groups and any recreational groups, advocacy, education, and awareness into other languages. We are starting with Spanish. We have expanded our signature support groups to Conexiones, which is in English, our connection support group. And this is for individuals that are experiencing or in recovery of a mental health condition. These support groups are led by peers as well. So that would be people that also have a mental health condition. So we're very happy to share that that is in Spanish and English now. And then we have in Spanish also the Grupo de Apoyo para Familiares, which is a family support group. This support group is for individuals that are that have a family member or a loved one with a mental health condition. And again, this is an English signature group, and we are now offering it in Spanish. These groups are going to be eventually be provided on site. Currently, we are offering them via Zoom, online only, but the goal is to have 2 groups available for connections, one during the week and one on the weekend for when people can't attend either or. And then we have the Zoom virtual availability. Additionally, we are working with other communities. We have reached out to the Laos community, the Mandarin community, Chinese community, and other communities so that we can eventually provide these groups in other languages as well. I know that it's going to take us a while, but our dream is to have it at least in the 5 top languages. We are working very hard to do that. In addition to spoken language, we are also reaching out to the deaf and hard of hearing community. We know that there's also a need there as well. And so this is the things that we are working with. We are very excited about expanding our equity and inclusion reach. We have been reaching out to other communities for other items that we can partner with. And with that, I will leave it to Andy to go on to talk a little bit more about practical lessons learned. So thank you for your time.
Oh, I thought you were going to talk about this. I guess, the one thing I would say about the 2 new programs, Sharing Hope and Compartiendo Esperanza, is that they've been, they're conversation starters. And really, in terms of building the capacity of our organization, we're seeing this as a wonderful way to recruit more very talented, very committed folks from Black and Latino communities, and begin bringing them in to be facilitating all of our programs. So that is an expansion strategy that I think Laura's probably gotten about 50 people through our the orientation at one way or the other in 9 cities around the state. So that's actually really exciting and going to be bringing some new talent that we really need to the table. So just Laura, actually, these are really for her experiences, but just some of the things that we talked about in terms of building relationships. You know, I've actually spent most of my career working in communities of color, mostly in the city, but other places. And my experience has always been that building commitments and building networks and relationships kind of works the same with everyone. And the biggest thing to do is to get moving. So we do go, and I think especially me, you know, I'm a white man, you know, I think when I am going to a community, I go as a visitor and a guest. And so I really start by asking a lot of questions and listening to what people say, because for the most part, you know, people understand their own communities, they understand their own need. And there's a lot of people that are already doing really wonderful work that we just need to support. I know, Laura, you think this connection's all around. You're the Zoom person. What do you?
Yeah, I was going to ask if you want to start sharing your screen.
I was
I'll
just
stop
saying
in
that Laura's developed a specialty of using private chat to build relationships in some of the meetings. You know, what we see is that we have opportunities really to connect with providers and CBOs and leaders in every community. It's taking the opportunity to reach out one-to-one. You know, the other thing is your own networks and association. I was really impressed by looking at some of the stuff that, whether it was a state or national psychiatric society, looking at you know, racism in diagnosis, looking at asking really hard questions. So you know, starting with where we are or where you are is going to be a good step. The other thing that we would say is, in terms of building partnerships, is to specifically ask for collaboration. You know, ask how we can support your efforts, and not necessarily selling our efforts. We kind of do that after. And generally, what we found is that most people already have something going and are just, you know, welcoming support. We also try to bring value, not just a speech. So what I really like about Comprendo and Sharing Hope is that they're very useful and user-friendly, and they're by, for, and about the communities that they serve. So bringing that to folks is something that adds value, and that's about it. I think that's pretty much it. We build networks by asking people to bring other people, and it seems to work pretty well. I think we could stop talking there. Laura, did you have anything else to add?
No, I do not.
We're really grateful to hear what our friends at Thresholds are doing, and look forward to finding ways to work with the Psychiatric Society.
Yeah, so thank you, Andy and Laura, and thank you for sticking around for questions after this too. So next up, as far as presentations go, we've got Dr. Cook and Dr. DeVitt from Threshold.
And I'm going to actually start off, Dr. Houston. I want to, because we're going to hear a presentation today from Thresholds, and I'm Steve Weinstein, the president of Illinois Psychiatric Society. I'm also the medical director of psychiatric services at Thresholds. And I want to thank profusely Wesley and Tim for coming today. Dr. Cook is a family med physician. Tim is a psychologist. What are they doing here, right? They're here because we have a great program, and I asked them if they would share what they do. For those of you who don't know Thresholds, we're an organization that's been around for 59 years, providing community outreach services, psychiatric services, and now primary care services to people with severe mental illness and addictions. And today you're going to hear about a program, and I'm going to give you my little blurb about Tim and Wesley too, if I may. Dr. Cook is a family medicine physician, he's been on the vanguard of providing medical services since he's been a physician. The tragic unfolding of HIV and the AIDS epidemic clarified his interests and focused his work. Early on, he delivered babies of HIV positive women when most of medicine was hiding from this population, right? He worked with IV drug users who were HIV positive, right? And this focused his, if I can speak for you, sir, he crystallized his interest in addiction medicine. He has been board certified in addiction medicine for 30 years. So, he was a pioneer in harm reduction in addiction medicine when addiction treatment was tough love. He was an early adopter of Suboxone, buprenorphine, and has been prescribing it for 20 years. He's also medical director currently even of Chicago Recovery Alliance. And Thresholds, and I am just so appreciative of all his talents. Tim Devitz, psychologist, is masterful at building programs. The APA awarded the program Tim built the silver medal in the early 2000s for a residential program serving people with SMI, substance use disorder, and homelessness. And that's how I got to Thresholds, to be hired to work for that program. And today you're going to hear about another program Tim built along with Dr. Cook. So please go ahead.
You're muted, Dr. Cook.
Yeah, just caught that. So thank you for that very nice introduction, Steve. I really appreciate that. And how much time do we have so we stay on track with time? We're supposed to finish at what time for questions? So
We usually like to leave about 30 to 45 minutes. So I think you could still have about another 15 to 20 minutes if you need it.
So 15 or 20 minutes for our presentation?
Mhm.
Okay, thank you. So I'm going to let you read the objectives there. So you can
Yeah, let me make sure I got those. Do I have control of the slides now? Can you all see the slides?
Who's posting the slides? Who's share screen?
Tim.
Who's doing it? You are? Okay.
And Tim. Yeah.
We can't see them, Tim.
Okay. How do I get? I'm sorry to take time for this. How do I get control of the?
You should have
board?
control. There should be a share screen button at the bottom.
Do I go into settings for that, or do I go into?
Should be, if you hover right at the bottom of the Zoom meeting bud, right at the bottom, you take your mouse and hover, it'll say share
Oh,
screen.
I see. Okay,
Okay.
sorry about that. I've got it.
It's okay.
Now. Yeah, I got it. Mhm. I don't know if you can see him now. Can you see him?
No. Do you want to send them to me, Tim, and I can share them? I'm sorry, I don't have them.
If it doesn't work, I can do it from right here. I have them.
Why don't you do it, Dr. Cook? Just put them
Okay.
up and we'll,
All right.
Tim, tell us to go with to the next one, okay?
Okay.
Here we go. Can you see them now?
Yep.
Okay, I'm going to let you read the objectives and then give you a second, and then I'm going to go to the next slide. I'm going to move to slide presentation show. I wasn't planning, so here we go. There we go. There's the objectives. I want to show you the first slide here, showing you the.
Wesley, they're too big for the screen. Can you just go get it out of this mode? I'm sorry. We want everyone to see the slides.
Okay, is that better?
What do you guys see? I'm sorry.
The other version was actually working fine on my end.
Okay, I guess
Okay.
it was just mine. I'll shut up then.
Okay. Okay, so let me go back to this slideshow. Sorry. Okay, this was what we saw at the beginning of the pandemic, a rash of increase in opiate overdoses at the beginning and at the first months of the pandemic. And the data revealed that. Why I think it's relevant for us to be here speaking with you with the topic we're on, as you can see, in this slide, you see a difference between Cook County, and this is national numbers. So here are where nationally the overdoses are predominantly in the white population, with of course the Black and Hispanic population being represented. But when you look in Cook County, hold on, let me switch back, there we go. And that's Cook County. So you see that it's disproportionately affects the Black population in Cook County. And that's obviously our program is on the west side and on the south side of Chicago, and the population that we serve. Can everybody hear me okay? Making sure the volume's okay, okay. And this is a photograph of us actually out in the community, where we partner often at the libraries where the naloxone is available, and also in the police districts where our arrest deflection program is located, where you're going to hear more from Tim in just a moment. But try to be present in the actual communities that we serve. This slide, I believe number 7. Yes, this is a slide to illustrate in our harm reduction model, which in addictions medicine, particularly in the early years when I first began my training in addictions medicine, it was all about abstinence, and of course abstinence is still really relevant in in some aspects of recovery with certain addictions, but certainly with opiates and opiate dependence, then the concept of abstinence is defined differently. And in a harm reduction model, the idea being that you continue to make progress and reduce the harm as you provide the treatment and provide the engagement. And I believe that any positive change is also a phrase that one of our colleagues, that one of our partnerships that we're going to be speaking to you, which is one of the items we're supposed to address today, is partnerships. We'll be talking about later in the presentation. And this one, I believe you take from here, Tim.
Yeah, everyone, you can all hear me okay. Thank you, Wesley, and thank you, everyone. I just want to clarify that I'm a LCPC, licensed clinical professional counselor, certified alcohol drug counselor, not psychologist. But I want to emphasize the importance of the harm reduction model in the work that we're doing to address the needs of the individuals that are in the communities that Dr. Cook referenced in the earlier slides. It really touches on us trying to meet people where they're at, and not only work with them if they're willing to be sober or willing to engage in abstinence. We definitely encourage and work with people to become abstinent, but we have a lot to offer people who aren't there yet. And this slide, it really speaks to that. We kind of think of housing and health access and engaging in meaningful pursuits such as work, having community, having relationships and connections in the community that are not just about substance use. That's really foundational for recovery, and that often that does come first in our book. It's not something that comes after people commit to sobriety. It's something that comes first, whether people are interested in sobriety or not. And so we have that mindset in the work that we're going to share here. We can go to the next slide. The examples that we'd like to share today regarding building of community partnerships have to do with three areas that we've been directly involved in for the last few years. One is partnership with the Chicago Police Department, actually, and a number of other organizations that help support the work that we're doing to arrest or to help people that have been arrested for nonviolent drug-related crimes really get like a get out of jail free card and work with us and not have anything on their record, not have any felony charge from this offense and work with us. So it's arrest deflection. The second is a street outreach and engagement effort that we've been partnering with a number of organizations to implement since the beginning of the pandemic, spring of 2020. And then throughout both of these examples, and then Dr. Cook will continue, we'll talk about just our emphasis on helping people access integrated care, health care, and that includes medical care, integrated mental health care, and substance use care. And it could be all three, it could be one, it could be two, whatever, or whatever the person is in need of and interested in and willing to engage in. Kind of where we're going with that. And the idea is that it's immediate. It's not something that we help them to get an appointment for down the road, but we're working and partnering with others to help that happen immediately when they're right there when we're with them. Next slide, please. So this narcotics diversion program and treatment program started in 2016. We got this call, from the University of Chicago Urban Labs, asking if we'd be interested in partnering with them. There was it had already started a few months earlier with the Chicago Police, the High Intensity Drug Trafficking Agency, the Chicago office, and a few other providers. And one of the things they were noticing early on was that they were interested in more of that harm reduction approach to the substance use work. They had some other providers as well. They asked us to join up. And so we got involved and did. Next slide, please. And what we were able to, actually this kind of got looks like mixed up. Is there another slide? Maybe we can go to the next slide. Yeah. So there was an emphasis at this time on arresting people, going to jail, and then they go to the Cook County Jail, and they go to they have to go to court, and a lot of times these charges were dropped, is what they were showing. However, there was still time spent, time spent in the Cook County Jail. Court cases were getting tied up in with Kim Fox's group, the state's attorney, and everything there. There was just a lot happening there. And what the police basically said, and what HIDA has said, was that, we're spending a lot of time arresting people, and they get out quickly, and they don't have nonviolent offenses, and it doesn't seem to be making a big impact on crime. It doesn't seem to be making a big impact on the increasing rates of overdose and substance use in the community. And next slide, please. We'd like to try treatment, and so we were very interested in that and working with them. I think where this treatment emphasis, I think what we tried to help with and continue to try to help with is expanding the definition of treatment. That treatment doesn't only involve going into detox or going into med stabilization and stopping use. Of course, that's something we want to assist people with and encourage. And now with outpatient induction on Suboxone, we don't even always need the institution's inpatient or detox days. But even with that, not everybody's interested in that. So broadening the definition to include some of what I shared earlier in that slide from SAMHSA about housing, healthcare access, and about income, community connection. Next slide, please. So we signed on for this project, and we worked with the police, and this is our staff here, and basically we're working through a one-way or two-way mirror with the people who are being detained. They're offered the opportunity to meet with somebody instead of getting prosecuted or going through the arrest process. Majority of people agree, and so we'll do a screening, and then we work on some linkage or connection to care. Majority of people don't go to thresholds. Some do. Some show interest in some of the work that we do, but we really try and meet them where they're at and connect them to the services so it may be that somebody's in Pilsen or in the Little Village neighborhood where Andy was referencing some work happening. We may refer there. We may refer to, depends on where the person's at, the person's from. Our location is at 3015 West Harrison. It may not be the best spot for everybody to go get help. That's in the East Garfield Park neighborhood, of Chicago. So it really depends on where the person's at and what makes sense for them. But we strive to do a brief follow-up with people. So if we link somebody, when we link somebody, we'll follow up with a call or connection to see if they made it, how did that go. For people that come to thresholds, then we offer the the full array of services, including we have recovery coaching, which I think is really important. And we've kind of broadened that definition to, it's not just about, or broadened the definition of recovery to, it's not just about helping people who have achieved abstinence maintain. It's also about initiating recovery too, through some of these pillars of housing, connection with healthcare, connection with employment and community. Next slide, please. So this was the slide that talks about our initial outcomes. 2016 and into 2017, we were actually working with the narcotics division of Chicago Police Department, and so we weren't regularly going out. We weren't with them every day. They would do these stings. They called them stings, and a sting is where they know there's typically what would happen is they would arrest somebody at a higher level with the drug selling activity, and then they would come in the next day or within several days, come in and do a sting where they would arrest a lot of people. And the idea was to send a message that this isn't going to happen in this spot. That the selling needs to go someplace else. And that was one of the strategies they shared with us in terms of why they would do these things. In addition, for us, it was an opportunity to see if people might be interested in some help. And so they were arresting these folks. They were doing these anyway. We came in as a group now that would do these quick screenings and see if people were interested. And so over the course of that year and a few months, we served about 87 people we connected with. And what I think gave this project some momentum was that the recidivism rates of the people that participated were low, and compared to the people that compared to other data that they had about recidivism. And what also was showing to be promising was that people were meeting with treatment the next day. People were meeting in treatment up to 30, 90 days later. And so it was enough. It was promising enough for us all, including Chicago Police Department, to say we want to do more of this. So at that point, the emphasis became, narcotics help demonstrate that this could be potentially helpful. So what happened after that is it moved to a district, actually East Garfield Park District, where we went into the police station where you saw that person working, and every day, 365 days a year, 8 hours a day. So it was always, what 8 hours do you find here? And the data was supporting that if we came later in the day, we would be able to see more people than if we did it earlier in the day. They wait for us basically until we get there at 3 o'clock now. We stay till 3:30. We stay till midnight, and every evening, every morning at like 2, 3 in the morning, they clear out the holding areas and everybody goes down to the county. So, and there's very few people arrested typically for these charges after midnight. So we're there serving people during that time. Next slide, please. So I just kind of, before I get into the outreach, what we were able to show here.
Do you want me to go back to that one slide that was out of order? Was that the one that I was supposed to
that
show?
would be helpful. Yeah, thanks.
Okay, I think I can.
We can go up a little bit. Yeah, I think I'm sorry. You can go back to that. Yeah. But what
this one right here, is
basically
this the one that you were looking for?
Yeah,
right
that demonstrated why we started in Garfield Park. Just that there had been, of all of the districts, CPD districts, there had been we were seeing the highest rates of overdose and narcotics arrest compared to the other districts. So just without the slides, we were able to demonstrate over the next 18 months that the recidivism count continued to show to be lower than for the people who didn't participate. And in addition, we saw consistency in terms of people engaging in care. One day, the next day, and 90 days later, it wasn't full. It was like under 50%, but it was still promising. And with that, the CPD and the mayor's office wanted to make this citywide. So we started by going out to all the West Side police districts. And then just when we were getting ready to go citywide, in beginning of 2020, we hit the pandemic, and basically people stopped getting arrested for these crimes. So on the one hand, that's like a positive thing for us. We don't want to see people necessarily always get arrested for these types of crimes. But what we do want to have is a pathway to engaging with them. And so we kind of recalibrated or pivoted a little bit, and we connected with the West Side Heroin Opioid Task Force, which was beginning to do this work, going out into the community, canvassing the area, doing a lot of naloxone education and distribution, and then we joined up, as have others, to assist with that, but also to begin conversations about recovery and using that definition of practical assistance with housing, practical assistance with income, practical assistance with healthcare, and of course, sobriety. If people are interested in getting into detox or med stabilization, we bring that up, of course. But it's about meeting people where they're at and working with them. So we started working to do this outreach, and what I'm going to share next, before I pass it back to Dr. Cook, is what we've learned. What are some of the essential ingredients to this street outreach? And partnership is key. It's all about partnership, and it's all about, as Andy said too, really finding out what people need. I don't live in the community where we're doing this outreach. It's really about connecting with folks and seeing what we can do, seeing what they see as important for them, and trying to help make some of that happen. Next slide, please. So we basically do our outreach in this area. About 6 months ago, the Chicago Department of Public Health started producing these. They call them heat maps, or they call them heat maps, and it's really it shows where the EMS responses are for overdose, heroin overdose, opioid overdose calls. And you'll see that little yellow spot there in West Garfield Park. It's yellow and red. That's right on Pulaski Avenue. You see 290 runs just south of it. There's an L stop there. There's a bus on Pulaski. There's a lot of people coming to this community to buy and sell heroin, or it'll say opioids, because there's a lot of analogs now that are in the supply in terms of what people are buying. And we spend a lot of time there. We also go to these other areas too, with other providers. I want to make that real clear. It's not just us going out there. There's a number of groups that are going out there that are part of this work, and that partnership with them is really important, because it's tough work, and to just have one or two staff out there, it just doesn't feel as safe, for folks. There's a lot of drug dealing. There's a lot of crime. There's a lot of concern, I think, about being out there when there's 6 out there, 8 out there at a time doing this work, and we may not be doing the same work. We may be doing, some of us are doing, there's medical providers out there, there's substance use treatment providers out there, there's a lot of people with lived experience out there doing the initial engagement. Next slide, please. I'm just going to keep adding to that. But that's one of the things we've learned early on, is that this effort really does need to be led by people who have the lived experience of often homelessness, recovery, mental health, substance use conditions. And every time we're out there, we have people that are being paid as part of their work. They work in this field now, doing this important engagement. They work for us at Thresholds. They work for Prevention Partnership, which is like the lead organization with the Oversight Opioid Task Force, and a number of other providers that are out there too. Next slide, please. Offer free naloxone and PPE is during this pandemic. It's really critical to offer the PPE, and then educating people about what naloxone is, educating people about it, and I don't have this on here, but also adding the fentanyl test strips, offering people opportunities to test their substance, showing them how to do that, and then giving them the kits to do so. Next slide, please. Also, it's about meeting people where they're at and offering them the services that match their level of motivation to make any kind of positive change. That includes, next slide, please, offering practical assistance with getting started, applying to All Chicago, which is where all of the centralized, requirement really by HUD that if any organizations that are receiving federal money to do housing have to do their waiting lists through All Chicago or whatever city. Every city has its own way of doing this, but in Chicago, all the organizations work through All Chicago. So we have to get people registered there so that they become eligible for subsidized housing. But that requires having a state ID. They may also, in addition to housing, be interested in medical care, first aid care, direct connection to medication-assisted treatment. First, next slide, please. And it's just emphasizing that the importance of that state ID for so many people that are out there. They don't have a state ID. They've lost their state ID. They've lost their bag the state ID was in, and it takes work to get a new state ID. Oftentimes, we have to get the birth certificate, the social security card. Sometimes those offices were closed during the pandemic. They were trying times, but it's getting better, and but we help people navigate that process to get that so that they can get back on that housing waiting list. Also get their medical card, be able to pay for the medication, and all sorts of things that I. Next slide, please. We've also established a lot of partnerships with medical providers that do medication-assisted treatment for addiction. Suboxone, for example, and these are some partners that we've been able to set up with now. And they've actually come to us too and said, we can help you. They've for different strategies for doing it, but we can get people in the same day for Suboxone. A lot of places have no shows. They have clinics. They have no shows, and so we can tap that. But it's been wonderful to connect with folks that organizations that are able to help with that. And the Threshold isn't on here, but we also, through Dr. Cook and some of the work he's going to share, we also are able to get people, in to see our providers as well. Next slide, please. And immediate access to immediate or access to healthcare is really important too. Organizations like the Night Ministry, Rush Street Medicine as a team, UIC Mile Square has been awesome at working with us. COIP is a program through UIC Public Health, Community Intervention Program, Lawndale Christian Health Center. Just a few examples of groups that are out there that partner to do medical care. It may be people come out, we can get people to them, but they're out there too, often doing this work and doing. We can even call the Night Ministry and say, hey, we met somebody, and we're at this location, and they'll either come over or make arrangements to meet with the person that day. Next slide, please. And just to end with, the idea of these pictures are actually in a Sun-Times article back in December, and so there was permission. People were given permission to be in these. The idea of approaching this work with the understanding that these are, the population is really struggling and that they're in dire circumstances, and we, striving to kind of meet them where they're at and helping them to navigate and make some positive step forward, and trying to lower the barriers to access and care. I think these are calling care, meaning medical care, substance use care, mental health care, but also that foundational those foundational components to recovery housing. And that's what I have. So thank you so much. And Wesley, Dr. Cook has just a few more slides and we'll be done.
Yeah, and we at Thresholds are now attempting to make our effort to deliver primary care in the same population of individuals and integrate our healthcare. And having been in practice as long as I've been hearing that buzzword of integrated healthcare for quite some time. And I've heard that definition be described many different ways over time, but ultimately I see it as bringing mental health, substance use, and primary care and specialty care together. And I put together this slide really as a result of what I've learned working many, many years in the commercial world. My private practice, for those of you that are familiar with the Chicagoland, is in the Roscoe Village area. And I've been under the expectations of a successful, sorry, my phone just rang, a successful integrated network advocate healthcare, and had to do population management for most of my career and perform on a variety of different measures, and have learned that, that many of the tools that I use in that population are also going to be tools that is going to be required to perform in this population of individuals. And you are trying to help them break down the obstacles that in front of them to prevent them from getting their mammogram, their pap smear, their colonoscopy, or whatever the case may be. Help clarify who is the team that's going to help them to accomplish that, and clarify that you're going to be using multidisciplinary resources in order to meet all the measures that the individual is going to need to meet in order to meet the metrics of quality healthcare. And while now we have the new buzz term of social determinants of health, those of us that have been practicing for a while recognize that that's just a way of describing something that we all learned quite a while ago in the beginning of our career, that social determinants impact on people's health, no matter the color of their skin, no matter the geographic location, no matter the language that they speak. But right now, that is an important concept in population health and quality healthcare, and also making every effort to make sure the patient, or often referred to as the consumer, understands the importance of achieving those health measures as the way to define what is called quality healthcare in the 2022. The other significant part of what we do at Thresholds is education. And one of my responsibilities is to teach the addictions medicine fellow and fellows when we have a addictions medicine program with Rush and with the University of Illinois. And we plan on taking those fellowships and the representatives of those fellowships and incorporating them in our primary care model, so that we'll be delivering primary care, addiction, and mental health in our integrated health concept. This slide here is for those of you that aren't sure. One of the things that Tim and Steve and I talked about is, what is it we can ask you to do from the place that you're setting? What can you do what action can you take with this population? One is to learn how to prescribe naloxone, and it's quite interesting for me as a provider that's been in practice as long as I have, because I used to be the one that would sign the paperwork to get Chicago Recovery Alliance to be able to get their naloxone, because they weren't able to distribute it to people that were IV drug users, because it was required a prescription. So I'd have to sign the paperwork to allow Chicago Recovery Alliance to get the naloxone to distribute in the neighborhoods that would prevent so they would be available for people that when they did overdose. Now, granted, the politics have changed, and the people that have been dying as a result of addictions has changed. And so therefore, naloxone is much more available than it was before, but you yourself can easily write a prescription, no matter, that your specialty is in psychiatry. You can hand the person the prescription and they can get the prescription, and it's covered by all the plans. It's now a state law that every insurance has to cover naloxone. You can also learn how to prescribe Suboxone, which the barriers there have been broken down tremendously compared to when my career first began. How difficult it was to become a prescriber of Suboxone or buprenorphine compared to how it is now. And that obviously is the one of the single most effective thing we can do with people that are struggling with a dependency on opiates. I believe this is your slide now, Mr. Devitt.
Yeah, so another way people can also get naloxone is all of the West Side and South Side libraries have it now. People can have it, can access it there. And you can also email the Chicago Department of Public Health and request to have naloxone and fentanyl test kits. And it can be just provided to people, handed to people. They need to be shown how to use it, but it how to self-administer it. But it's something we can just give to people. We keep it in our location and we hand it out.
I think that slide might have been out, and we're back to Chicago Recovery Alliance. This is a picture of the. Is this one slide, George Tim? Did I just speak over you? I apologize.
No, this is good. But this is what we both know. The Chicago Recovery Alliance, and this is their van, and they go out to different parts of the city and do harm reduction work, primarily, including testing of drugs for people. What are the analogs? What's in their substances? There's a website there, and they do great work. I can't say enough about the important thing in the community.
Distributing clean needles and the naloxone, so it's both the needles and the naloxone.
If you back up one slide real quick, the van, is the van on there, Dr. Cook? Oh no, the one more back. Yeah. This is landmark.
I'm sorry. Right there. Sorry.
That one. Yes. So this is UIC Mobile Medical Team is now able to prescribe, or at least they're actually you spoke with the physician
Stockton?
over there, Dr. Cook,
Yeah,
right?
Stockton Mayer.
Yeah. About what they're doing. They're doing Suboxone now, or
correct. They're prescribing from the van. And I don't think they're dispensing, but they're prescribing from the van.
And of course, the night ministry's out there doing. They're not prescribing Suboxone.
They're prescribing, but not dispensing.
Yeah.
This is your slide, I believe, Tim.
Yeah. So this is also, we were talking with Dr. Nicole Gestala, who's leads the addiction medicine, actually behavioral health program at Mile Square Health Center, is also the director of the medical director for SUPER, which is the Substance Use Prevention Recovery Division of the state of Illinois. And there was an encouragement to register with the helpline. There's a tab for providers to register their information, access care, and then also. We've been discussing this for some time, and she shared with me about 6 weeks ago that they're actually getting really close now to piloting an after-hours medication-assisted recovery telehealth service where they're looking for a cadre of providers to be available to meet with people telehealth. But it's this idea again of having access when people, and oftentimes that's not always 9 to 5, and during business hours. So they're really working to develop that and have that. And then this last slide is the overdose prevention sites, and to know about those and utilize those. There is not one in Illinois. There's one that's open to New York City. We have some colleagues that just came back from a visit to that one. This one, the photos here are from Vancouver, where basically it's a site where people can go and self-administer their substance, and under the, there'll be a person there who's trained in the lock zone administration who can be there to assist if needed. But there are also places where people can get support, number of things, healthcare, assistance with housing, assistance with a lot of good engagement. A lot of what we're talking about here under one roof, what we've been talking about tonight under one roof. And this kind of there's legislation in Illinois that's in the House right now that may lead to this happening here. It's not, but seeing movement, momentum.
And Madam Chairwoman, I believe that is the end of our presentation, so we'll turn it back to you.
All right, thank you. So Kristen, I think we're not going to record the Q&A, right? So that people can feel a little more free to ask whatever they want.